We are starting off with the second day of our conference, and the organizers hope that this day will be just as fruitful as the previous one. We are getting many reviews, which is great. Our first discussion today is about industrial hygiene of remote sites, health risk assessment for remote workers. Professor Andrei Korchevsky will be facilitating us remotely from the USA. And Boris Revich and myself will be here to help him just in case. I would like to preface with a short comment that I addressed yesterday already. It is no coincidence that the issue of risk assessment is a part of this conference. Unfortunately, the concept of risk assessment of the employees' health is actually not in demand in Russia, or it is performed not in line with the best practices. There are some practices and methods of doing it, but in general, they do not satisfy the demand of the world we live in today and the achievements of the world best practices. That is why we are trying to promote the significance of this concept in Russia. And generally we are confident that our efforts will be successful. Yet Russia continues to be integrated into the global economy, and the requirements for large businesses in the world are universal. The main thing is health and safety of the workers, which is a global value. We hope that broader understanding of this will follow. I am honored to introduce Professor Andrei Korchevsky, who has gathered a genuinely stellar speakers here today. It's a rare chance to listen to such prominent experts. This is just great. Andrei, thank you so much. You get the floor. Thank you very much, Dr. Karpov. I'm grateful for this opportunity to participate in the conference and facilitate this discussion about industrial hygiene of remote sites and risk analysis for remote workers, health risk assessment for remote workers. We are all aware that the most effective way to prevent such situations is to prevent the possible consequences and prevent the diseases by using the risk assessment first. It is great to see that this topic is also a relevant topic in Russia. 2 years ago, I came to Tomsk in person for this conference. Today, we are all welcoming our stellar speakers remotely. Researchers for whom I have the highest respect, speakers represented different organizations in the US. And I'm confident that industrial hygiene of remote risks, health risk assessment and prevention of the diseases, the role of its prevention, especially during the pandemic, will be something that we will discuss in great detail today. Unfortunately, we do not have so much time, so let's call it a brief introduction, and I hope that next year, in a year, we will be able to meet in person in Tomsk and invite our speakers to the conference and talk face to face hopefully we will have a chance to share our experience and the information, and share the best practices important for the development of the qualification of the medical workers in remote locations and remote healthcare in Russia and globally. This is extremely important. Our first speaker today is Lawrence Sloan, and it's an honor to introduce him here today. He is the Chief Executive Officer of the American Industrial Hygiene Association, which is a leading organization uniting professionals of industrial hygiene and holding adjacent jobs that have to do with the occupational health and industrial hygiene. Unfortunately, we are pressed on time to be able to share Larry's complete bio, but you have a chance, in case you're interested, to get more details on the website of the conference. Lawrence Sloan is an amazing person, and he is the most outstanding researcher I have ever met. Especially during the pandemic, he has put much effort into bringing the American Industrial Hygiene Association to a new level. This is a bright example of risk assessment, of health risk assessment, that is not just a separate methodology or a tool, but a global universal approach to the prevention of the diseases using medical knowledge, various tools and experience of different people in order to unite people and prevent the disease. The topic that Lawrence Sloan is going to share is American Industrial Hygiene Association interventions during the pandemic, the role of industrial hygiene community in the times of crisis. Thank you so much, Mr. Sloan, for joining us today. I can't wait to listen to what you have to say.
And I'd like to thank the organizers of this very prestigious event for inviting me to present. This is the first time that I present to the particular audience here. So in the next 15 minutes, I'm going to just spend some time talking about the organization, the American Industrial Hygiene Association, AIHA, a little bit about who we are, and then what our response has been to the pandemic. As Andre said, the last 18 months has been quite chaotic, as you can imagine. I am leading the organization, like many others, virtually. We have not been in the office for the duration of those 18 months, and so everybody is working from home. All of our meetings are virtual. Our board meetings have been virtual. Everything is through the internet. So it has been a challenge, but we have really managed to succeed in wonderful ways, quite frankly. The way that we have collaborated with the membership and to bring ourselves together to develop very important resources to address the pandemic. So with that, I'm going to talk very briefly, first off, about what is the AIHA's purpose. Our mission statement is to empower and advance those who apply scientific knowledge to protect all workers and the communities in which they work from occupational and environmental hazards. And my fellow presenter, Mike Larinaga, is going to follow me, and he's going to talk about the impact of climate change. And climate change, of course, is one of the key environmental hazards that are facing workers across all industries as we look ahead. So that is the purpose of the organization, and our vision is an aspirational statement. We would like to live in a world where all workers and their communities are healthy and safe. In our current strategic plan, we've created what we call a value proposition statement. This is basically a statement that the occupational health professionals can use when they speak to business leaders, when they speak to their clients, when they speak to people that are not trained in industrial hygiene. This is a statement that explains the value that we provide to society. And And so the statement reads that AIHA members are scientists and professionals who protect the health and safety of workers and communities by reducing risks and safeguarding operations to help organizations operate efficiently and without interruption. So that's a little bit of background on who we are as an organization. This slide shows what we call the organizational chart. And without getting into a lot of specifics, let me just say that AIHA is a rather unique organization. We are a nonprofit society. And on the left-hand side, you will see the AIHA logo. That represents the 8,000 members that make up the association. We do publish a peer-reviewed journal called the Journal for Occupational and Environmental Health. We have, on the right-hand side, we have two foundations. One is the Education Foundation, which awards scholarships to students. And the other is the Guideline Foundation, which, among other things, develops what are called emergency response planning guideline values. These are values that are designed to allow communities to know if and when to shelter in place if there is an accidental chemical release to the environment. So ERPGs are basically the community-based occupational exposure limit to a threshold limit for the workplace, like a TLV, for example, threshold limit value. So we developed those values over here. And then in the middle of the slide, we have three what are called limited liability corporations. The first is a lab accreditation practice, and these include industrial hygiene labs, predominantly in North America. We have what's called a proficiency testing program, which basically helps labs prove that they are competent in what they do. And then finally, we have a registry program, which consists of three different registries. Registries are basically like credentials. And there are two registries that have been around for quite some time. One is the Asbestos Analyst Registry. It's been around since 1974. And the other is a little bit newer, and it is a Safety Data Sheet Author Registry. So these are the people that develop the safety data sheets that are associated with chemicals. So that consists of the entire AIHA organizational structure. And what's not reflected here are the 65 local chapters that are around the United States and Canada. And so it is a rather complex organization, but a very robust society with over 1,000 members that are actively serving on the various technical and professional development committees. So let's switch over to what our response has been to the COVID pandemic. Back in the spring of 2020, when we still didn't really know a lot about the virus, we recognized that there were tens, if not hundreds of thousands of small businesses in the United States that were not receiving practical guidance from the US federal government. And so we decided as an organization that we had a responsibility to develop very clear and comprehensive guidance to help businesses, small businesses, reopen their operations carefully and safely. So we formed a task force, and the task force was called the Back to Work Safely Task Force. And so when we developed this task force, we sat down first and we thought, what is it that small businesses need to know? What are the things that the small business owner who doesn't know anything about occupational health, what is it that they need to know in order to safely reopen their doors? And we knew that whatever we developed had to be written in language that business leaders would understand. And that's not always easy to do. You have to translate the science of occupational health into language, into recommendations, into guidance that business leaders are going to understand. And so we decided that, first off, all of the directories, all of the guides that we develop were going to be designed for small businesses. And we decided that we needed to focus on small businesses because we knew that these businesses did not have the benefit of an industrial hygienist. We knew that the language had to be clear, it had to be concise, and it had to be very action-oriented. And the very first guidance document that we developed was for restaurants, a very critical part of any society. And we ultimately developed 27 different guidance documents, and I'll describe those industry sectors in another slide or two. And we knew that, again, we had to make sure that the guidance was tailored towards the comprehension of the business owner, the person who really didn't know anything about worker health and safety, but knew that they had to figure out a way to reopen their business. Because like many other countries at the beginning of the pandemic, all of the American society was shut down, with the exception of the medical community, hospitals, doctors' offices, supermarkets, and pharmacies. Pretty much all of the other businesses were shut down for a good 6 to 8 weeks. And so as we knew that we were going to reopen the economy in the late spring, we had to get this guidance document out into the society and get it into the hands of those small businesses that needed the guidance the most. So when we developed the guidance documents, we decided to develop the framework from 3 different perspectives. Number 1, what should the employer be doing? Number 2, what should the employees be doing? And number 3, if it was an industry where there were customers that were coming in from the general public, what were their responsibilities and obligations? And so when you look at these guidance documents, all of them are designed from those 3 perspectives: the employer, the employee, and if it's an establishment that takes customers, the patron or the guest. And at the back of each of these guidance documents, we also provide a listing of other association resources, including guidance from the U.S. federal government. Now, I will tell you that we are not always in agreement with the U.S. federal government. And so when you looked at the guidance from the OSHA, the Occupational Safe and Healthy Administration, the NIOSH, and the CDC, Centers for Disease Control, from time to time, our guidance has not been necessarily aligned with what those organizations have said. And we have decided that it is best for us to deliver this guidance, to develop these recommendations based on the science of industrial hygiene. This slide shows the traditional chain of infection between the source, if you will, and the host. And so as you read through these documents, we decided that the organization of the material would follow what's called the hierarchy of controls. Many of you on this call probably understand that the hierarchy of controls looks like a pyramid, and at the top of the pyramid is the most effective control strategy, which is elimination of a particular hazard, down to engineering controls, administrative controls, and then personal protective equipment. And so as you read through these documents, they're all organized from the perspective of highest, most restrictive control to the least restrictive control. And the purpose of the guidance is to break the chain of infection, to figure out ways to reduce the opportunity for the virus to transmit from the host to the receptor. So this slide shows the 27 different industry segments which we have developed guidance documents for. They range from amateur sports. So for example, in the United States, if you are a little league, which is a baseball coach, there's guidance for that environment, all the way to transit systems, buses, subways, as well as warehousing and transportation hubs. And again, the purpose is to focus on small industry sectors. So all of these 27 documents have been translated into Spanish, and we just released the version 2 of all of them in English, and we are going to be updating the Spanish translations of all of them in the next couple months. All of this information is downloadable for free. There is no cost, and you go to www.backtoworksafely.org. In addition to the Back to Work Safely documents, we developed a series of other COVID-19 resources. You will receive a copy of these slides. And there are hyperlinks on this slide. So each one of these names that is underlined in blue is a hyperlink to our website. And you can download all or any of these materials, again, free of charge. These documents pertain to the hierarchy of control. So for example, we have a guidance document on UV disinfection. We have other documents on cleaning and disinfection of facilities. Another document on the proper use of respirators for healthcare workers and first responders, and so forth and so on. So there are a variety of resources, and we invite you to take a look and download whatever you wish. So in terms of the theme of this particular meeting and the mission of your convention, why are AIHA activities important to remote workers? First of all, we all know that the pandemic has created very special challenges for occupational or industrial hygiene programs at any workplace, but particularly remote locations where you have isolated workers, and if you have service that is coming and going to the remote location, it opens up the opportunity for the person coming in from the outside world to carry the virus into the remote location. And so then what happens if the person coming in from the outside world transmits that virus to the workers in that location? So we know that our guidance in the Back to Work Safely and some of these other resources are very relevant and will be useful for those that work in remote locations, because breaking that chain of transmission that I mentioned on the other slide applies to any work location. The pandemic has also increased awareness about the importance of our profession. This has been a very exciting time for AIHA, and it's been a great opportunity to raise the visibility of who we are as an organization and the value that we provide to society. The challenge for us will be, once the pandemic is behind us, we need to maintain the focus on the importance of our profession in protecting workers from a variety of hazards in the workplace. And I am optimistic that this pandemic has basically raised the level of sensitivity about how important it is to take care of our workers, again, in remote locations or in conventional physical plant locations. And finally, I want to just draw your attention to one of our many guidance documents, and there's a link to real-time detection systems. We feel that the pandemic has accelerated the use and the importance of monitors, sensors that are worn on the worker so that they can measure real-time changes to hazards in the workplace, including, for example, noise and body temperature, blood pressure, resting pulse, things of that nature. These sensors that are being deployed and put onto workers in a variety of settings is being accelerated by things like the pandemic. So this is a very important time for the profession to step up and to explain how important and how critical we are to society. As I mentioned earlier, throughout the pandemic, we have worked very closely with the CDC, with NIOSH, which is the occupational research arm of the CDC. They are the ones that do research on a variety of workplace hazards, and they have a very robust respiratory protection department. And of course, OSHA, which is the Federal Regulatory Authority for Workers, and the Department of Homeland Security. They have a division called the Cybersecurity and Infrastructure Security Agency. And I put this on the slide because back in the summer of last year, AIHA was successful in getting industrial hygienists or occupational hygienists classified as what are called essential workers. So that allowed our members to be earlier in line to receive the vaccine once it rolled out at the beginning of this year. And getting ourselves identified as a essential worker is a very significant development for the profession. I'll mention very quickly that we have a lot of different associations around the world where we work together. We have developed communication pieces. We have worked together on webinars. We have put out press releases. We have provided subject matter experts that have gone to these other organizations and provided their expertise. As an example, we worked very closely with the American Dental Association last summer. They had some questions about the reopening of dental clinics and how dentists were going to be able to work on their patients with respect to aerosols. You know, when you have your teeth cleaned, you're doing work in somebody's mouth, you're generating a lot of aerosols, and that obviously creates an opportunity for virus transmission. So what types of engineering controls, for example, what types of controls in the dental clinic needed to be put into practice to reduce the ability for the virus to transmit? So that's the kind of opportunity that AIHA members had in working with our counterparts at organizations like the American Dental Association. Let me switch over to the more general topic of international engagement. Andre and I have known each other for the better part of the last 5 years, and we are very proud of the relationship building that we have developed around the world. We do focus most of our international activities currently on these 6 regions that are noted on the slide, but we also have a microgrant program that we're very proud to sponsor. About $25,000 a year is allocated towards these microgrants. And these grants are basically available to third-party organizations that are doing work in industrial hygiene in emerging economies around the world. The opportunity to apply begins now through the end of the year, and there is a committee of our members that reviews the applications and then recommends the awards of these small microgrants to the board of directors in February. They get approved, and then we distribute the monies thereafter. So AIHA, is a U.S.-based organization. We do as best as we can with global issues, but we're not an international federation. But we do reach out, and obviously having myself and my colleagues on this call presenting this morning demonstrates our commitment to broadening our horizons and providing our expertise and assistance to other countries. I'm going to wrap up very quickly by talking about a very special project. The AIHA received a grant, which is free money, basically, from the U.S. federal government, from the CDC, the Centers for Disease Control. This grant, we applied for the grant last year, and we got notice in February of this year. And the grant consists of 4 different projects. You can ignore the letters after these projects. Originally, we had proposed A, B, C, D, E, F, G, and it turned out that the grant scope was reduced to these 4 projects. But very quickly, what I want to mention to you all is that all of the deliverables that come out of this grant project are all going to be focused on end users. There's going to be a series of video recordings. There's going to be deliverables in terms of online tools. There's going to be an online risk assessment tool that you can use to decide whether or not your workspace is considered high risk or low risk, and what do you need to do if you're high risk or low risk. And there's going to be other resources that are going to be rolled out over the next 6 months. So you will be hearing more about these resources between now and the end of the year. And it will be an ongoing communications plan to really get the word out about all of these tools and videos and booklets that are being developed, all free of charge under this particular CDC grant project. I'm not going to spend much time covering the specific details of these projects, other than to say that, again, the focus of these deliverables is on smaller sized businesses. And as you look at these slides later, you will see that there is a theme that runs across all of the projects, and that again is clear, practical, common sense guidance that is delivered in language that small business owners and managers will understand. Okay. And finally, in terms of this grant project, we will be developing a communications plan, and the communications plan will be measuring how far we can reach with these deliverables. How much can we do to get the word out about these resources across the US and around the world, what actions are individuals taking in response to receiving and watching or viewing these deliverables? And then what kind of sponsorships and endorsements will we be able to recognize with respect to these deliverables? And there'll be a series of metrics that we put together to measure how effective our marketing strategy is. So a lot of very, very exciting developments, but I think my time is up. So I'm going to stop here and thank you very much for your time and attention.
Larry, we probably cannot hear the applause, but I'm sure that the public appreciate very much your great presentation, very interesting. We expected some questions from the audience, and the questions will be through me, so I am receiving them. But nothing yet. Probably people are still trying to digest what what message we are sending to them. However, I have a question, but very briefly, because we are already kind of a little bit out of the schedule. Nevertheless, AIHA did a lot of very interesting, performed a lot of very interesting projects. Have you ever tried to evaluate the business case, the metrics of the final efficiency? What was it? Saved lives, the economy impact on the organization you did, professional development. And I understand it's a very difficult question, but I just wanted to ask you, because for people it's interesting. Industrial hygienists, it's always a question of business case. How, what is your return on investments on each individual workplace of industrial hygienists, but also at the level of the organization?
So a very quick response to that question is that the demonstration of the value of our profession is something that AIHA is very actively working on. And to your point, Andre, the value is going to be very specific and customized to the industry that you are speaking to, right? If you're working with a restaurant versus a remote oil rig, for example, the value proposition is going to be very different. But one of the things that I want to communicate and leave with this audience is how important it is for our profession to speak clearly to people that are not like ourselves. How we communicate our value proposition, how we sell ourselves, and explain the role that we play in helping businesses solve real-world problems is something that we continue to evolve and develop as an association.
Larry, great. Thank you very much for your presentation and for this answer for my question, but we expect more questions from the audience during the session. Thank you. And
Спасибо большое.
Dr. Michael Laranyaga. Dr. Laranyaga is board certified safety professional, board certified industrial hygienist. He is a fellow, so it's very honorable position from the American Industrial Hygiene Association. He also is president and management principal at the organization named REM, Risk Consultants. And the topic of Dr. Laranyaga today is climate change impact on occupational health of workers. I would like to emphasize that we will have two presentations on climate change and the impact on the remote locations. Very interesting. This is kind of another important topic that is on the intersection, overlap of epidemiology, of the environmental science, the industrial hygiene itself, all science about remote healthcare. So what's going on with the climate change for the occupational workers? And Michael, I'm very honored that you joined this session. And please, it's your 15 minutes of presentation, 5 minutes for questions. Thank you.
All right, thank you, Andre. I appreciate it. And I'm very happy to be here with you today. I wish I could be there in Tomsk. I did not know a lot about Tomsk prior to being invited to this, but since then I've learned a little bit about Tomsk, and it seems like a beautiful and wonderful place, especially during the summer. So maybe sometime in the future we'll see you in Tomsk.
Sure.
Today we're going to talk about climate change and its effect on workers from a very macro level, because we've kind of seen some climate change effects. It's going to happen with regards to climate change is going to happen at least sometime in the future. So in many ways, we're using foresight to try and determine what the industrial hygienist needs to know in the future and needs to be prepared for, and then also, what the workers are going to look like and what types of workers we're going to need. So I like to start out with this because one thing that the pandemic did is that it really allowed us to rethink work. So prior to the pandemic, we were a little old-fashioned all around the world with regards to work. During the pandemic and likely after the pandemic, we now can do a lot of things remotely that we wouldn't probably have done prior to the pandemic. So what it's done is it's given us permission to rethink work. Now, I have a little bit of experience working in remote locations. This is the Karanjúkur Dam and hydroelectric power plant in Iceland, where I worked for almost 2 years. This was a very large project, and at the time, I think it was the largest construction project in the world. And it also involved the digging of 40 kilometers of tunnels through solid stone. And so this is a very interesting project for me personally. We did have a lot of challenges, and unfortunately, we had several fatalities and severe injuries during the project. Now, one of the interesting things about this, a very remote location, not nearly as remote as maybe some areas of Russia, but fairly remote. And the workers were Italian, so the laborers came from Italy. And so there were some issues, or I guess challenges associated with dealing with Italian workers, and especially many of the engineers were from the United States and Iceland and Canada and Germany and other parts of the world. So very interesting project for me. That dam was built specifically to support hydroelectric power for smelters in Iceland. And I also worked on this project, which was the Alcoa smelter, which is now Rio Tinto. So it's also fairly remote in Iceland, although not quite as remote as the dam, because you can see here it's on the ocean. It's in a fjord here. So one of the challenges we're going to have in the future is rapidly changing population patterns. So if we can see now, in 2007, there were 19 megacities in the world, with 13 of those megacities on water. Now, a megacity is a city with 10 million people or more. Okay, so you can see Moscow here, back in 2007, had about 10.5 million people. And back at that time, it was anticipated that by 2025, we would have 26 megacities with 7 new megacities. What's happened, it's not even 2025, and we have 33 megacities around the world. So that represents the bulk of the world's population. If we can see here, these 33 megacities are mainly in Asia. And of course, we would expect that because the 2 most populous countries in the world are in Asia. But and they're expecting another 6 megacities in the world by 2030. So what that tells us is, in the future, a lot of our labor for large projects and remote projects is going to come from Asia, and likely even from Africa and South America. And we can see that in Russia, there's 1 megacity, Moscow, right? And so it's very sparsely populated compared to Asia. But you're fairly close to Asia, so it would make sense that many of your workers would come from Asia in the future. Now, one of the aspects of climate change is that it makes existing things worse. So we know that we have warm days and cold days. We know that we have drought, heat waves, fires, and precipitation. What climate change does, it makes these things that we know very, very much worse. And so we can see this year alone, fires in Greece. We saw 2019 fires in Siberia. We saw the last several years in the United States, massive fires on the West Coast. and in Canada. And so we see that, climate change just makes things worse. Look at this image here. What this is showing us is the things that are necessary for humans to survive: food, security, economy, infrastructure. And here, I can't see. Oh, excuse me. I'm trying to move my health, right? And water. So we need these things as humans to survive. And if we can see that these climate change hazards, which we're relatively familiar with because they happen all around the world already, can cause disease, right? So at least 10 of those hazards on the left can cause disease. At least 9 of those hazards can cause conflict. And at least 9 of those things can cause damage to air quality. 8 can cause death and lead to pathogenic disease, mental health, and even vector-borne diseases. So we can see all of a sudden that these climate change hazards, which we're very familiar with, can cause these types of things. And matter of fact, what's listed here are impacts that have already been observed around the world due to climate change. So these are things that have already happened. And what we can expect in the future is for these things to get much worse. And because climate change is a threat multiplier, it makes things worse. Now, along with making things worse and making a threat multiplier, we have 2 acronyms here: turbulent, certain, novel, and ambiguous, or TUNA, or VUCA, volatile, uncertain, complex, and ambiguous. These 2 acronyms kind of describe the same thing. If we look at COVID-19 and the pandemic, we can see that COVID-19 fits these 2 definitions very well. But in the future, we will see that climate change impacts fit those definitions too. So what does that mean from an industrial hygiene perspective? It means that as industrial hygienists and occupational health professionals, we need to be better trained to deal with these types of things, to anticipate and recognize what the future may hold, right? And so we've seen these things already, and just talk about a few things. Increased ambient. A great example of this is the World Cup, the Qatar World Cup soccer stadium that is being built for the 2022 World Cup. Almost 6,000 people have died, most due to heat stress, most due to an increase in temperature. And so we can expect in the future that we will have significant severe injuries and fatalities from increased temperature. Along with increased temperature come, air pollution, ultraviolet radiation. So we could expect an increase in certain types of skin cancers. It will have extreme weather, which can lead to more acute hazards or acute injuries and deaths. And then what we'll have is we're going to have industries that are changing and emerging technology. The world is going to change very fast from an industrial space, and we're seeing that right now. A good example is batteries. All kinds of technologies and industries are ramping up around batteries as the center of those industries, because batteries are getting so good now, we can do all kinds of things with them. So we can expect that to happen, although we may not be able to predict what they are. We know that they were going to happen. So new technologies are going to come, and they're likely going to be much more helpful in helping us do our work and protect workers. Now, along with this comes some certain threats, and ecoterrorism is one of these threats. Now, this is the Karanjaka project that I talked about earlier. This is the dam, and you can see here a person has chained himself to this big dump truck to prevent work. And then you can see here people protesting, although they're not doing anything to stop work, they're protesting. In the future, because we expect to be much more conflict, we can expect to be sort of eco-terrorism associated with our projects, especially large projects that impact the environment. And this includes remote work projects. And these projects here are fairly remote, yet there's people there. We can expect this to be much, much more impactful in the future. And this is the Alcoa plant. And we can see here a person up on the crane, and me, I'm scared of heights, so you'll never see me up there. But we can to see this type of activity more and more with remote work. Additionally, with remote work and climate change and remote work, we're going to see a lot of opportunities. And I think this is something that doesn't get talked about enough. Usually it's the doom and gloom, and everybody tries to kind of focus on the bad things of climate change. And certainly there will be bad things, and not to take any emphasis away from those, but there will also be amazing opportunities. There will be new types of jobs that we have not yet imagined. And these will likely occur in remote locations also. We'll have new technologies that allow us to do new things. We'll be able to use artificial intelligence to solve problems. And although we don't know what those solutions might be today, we know that we're going to get there. Another opportunity, and Russia is going to be a big benefactor of this, is we're going to have new areas of exploration. Areas that previously could not be explored are going to be open for exploration, and that's going to bring with it new economies and new jobs and new opportunities for a wide number of industries and countries. Previously uninhabitable areas will become habitable. So those are a lot of good things that we can expect out of climate change, and I think we don't talk about those enough. Now, with respect to climate change and remote work, because we're going to have new areas open up that we previously could not access, remote work is going to be further isolated, at least for the near future, and far from civilization. You're going to have to do multidisciplinary roles, and I think a lot of remote work already understands this. For example, if you have a fire, it doesn't matter what type of worker you are, we have to put the fire out because nobody's going to come help you. Urbanization and the increasing move to large cities will make it difficult to find qualified employees. Now, I've also done some work in China, remote work. And when I started first going to China in 1996, the countryside was bristling with activity, lots of people, lots of farming. When I went back as early as 2006, the countryside was empty. Most people from the countryside have moved to cities, and China had built large cities to accommodate these people. But I don't think that's just isolated to China. It's happening all over the world. It's happening here in the United States. This will result in labor shortages and make it difficult to hire workers for remote work. And I'm sure you guys have already come across this. Hazards will be VUCA. They'll be new and emerging, and we might not know exactly how to deal with them. And we'll have to be trained and willing to deal with them, much like we have the COVID vaccine. And I'd like to think that industrial hygiene has been on the forefront of getting not only the United States, but the world through the COVID crisis, right there along with the medical professionals. We're going to have new jobs that we don't know what they are. Who would have thought that the government of the United States would hire people to monitor Wikipedia and do things like that just to make sure that the facts in Wikipedia were correct with regards to government activities. So in the introduction, we talked about risk assessment. Risk assessment will become increasingly important. And one of the reasons is because employees are going to demand it. Employees are becoming smarter. They're becoming more informed. They know their rights because they all have access to news and social media. And so they are going to expect better treatment in the workplace and safer workplaces. Yeah, I'm right on time. Yeah, so with that, thank you so much. And I look forward to answering any questions that you might have. But one thing, if I could accentuate, there will be lots of opportunities associated with climate change, in addition to challenges. Thank you.
Michael, thank you very much. I appreciate it. It's very interesting. So we still don't have anything from the audience Potentially they will send us questions later, so we will be able to direct them to you, and it would be interesting to for us to answer by email communication or some other ways to communicate back to our audience. Still, I have a question. In 2009, as you know, National Academy of Sciences of the United States developed a paradigm of the risk assessment specifically recommended for governments. And they said that it should be a cycle in 4 steps: hazard identification, exposure assessment, dose response, and risk characterization. It sounds a little bit specific for quantitative assessment of health conditions of people. But do you think that this paradigm could be applied to the situation of climate change and specifically for remote workers? And we can kind of try to direct governments, not only in the United States, meaning government agencies, but governments around the world to step by step evaluate what's going on to happen.
Yeah, that's a great question. I think I'm familiar with the National Academy's risk assessment, books and methods. I think those can be applied, and I think they are applied already, and they've gained a lot of traction. I do think they'll be useful in helping governments assess risk and with decision making associated with those things. Now, of course, one of the aspects is you have to apply the methodology correctly, and so that's and then one of the other challenges is risk is relative. So one country or one organization might perceive risk as one way, and you or I might perceive it as another way. So that's always a challenge, and risk also is cultural. So different cultures assess risk differently. So I think it can be, but then I think there's some probably challenges to get it systematically applied around the world.
Great, thank you very much. This is what I anticipated, and it's great answer from your point of view. Thank you very much, Michael. Our third presenter is Mr. Benjamin Woodrow. He is also board certified safety professional, and he is board certified industrial hygienist, but he is also a paramedic. And our audience, many of our participants in the conference today are paramedics or people working with the paramedics expertise. And Mr. Woodrow works for Chevron North America, specifically he is health and medical advisor in the Gulf of Mexico operations of Chevron North America. Chevron, it's a great international company. I had chances to collaborate with some of the branches of this company in the Republic of Kazakhstan many years ago. And so it was great for me to listen and to hear news about the progress for this company regarding remote workers. And the presentation that we expect today is very interesting, and the topic is offshore COVID response and health assessments. Benjamin, please, thank you very much for joining us today.
Hello, thank you, Andre. Just an audio check real fast.
Yeah.
Okay, I'm seeing myself on the shared screen here. You see my presentation okay?
I do, but I don't. Okay, yeah. Sure.
Hold up now. All right. Yeah, thanks, Andre. Thanks, everybody. It's an honor to be invited and to present, although virtually, like others stated too. Hope to be there in person as soon as next year. So maybe this will set the stage of what we can continue on and hopefully talk about maybe the end of the pandemic and how we learned and apply our knowledge to future epidemics and hopefully, mitigate, from getting any bigger into the actual pandemic. So thanks again for the opportunity. Just going to share our stories like what Andre said. Larry set the stage very well with the IHA background. I'm a member of, like Andre said, industrial hygienist for about 10 years now. I've been in this role as the medical advisor and lead for the Gulf of Mexico. So just to give you an idea, in the Gulf of Mexico, we mainly operate now in the state of Louisiana. My main base is in Covington, Louisiana, which is outside of New Orleans here. But most of our assets are called deep water assets now. It's in the deep water, unlike the shallow water, where we have production platforms that are mostly floating and tied down to the ocean floor, and we produce the oil back to the shore. But of course, we have to start with drilling, exploratory before that. So it's a lot like situated like cruise ships offshore, and as y'all are familiar with, but I'm not sure exactly what type of assets you have there in Russia. Most of our facilities will range from about 60 people on board, some of the smaller facilities, to about 200 people on some of the drill ships or some of the drilling rigs. And as you see the distance here, which involves our team from the medical and IH perspective, and the challenges, especially in remote environments, is the need to plan in advance. We're not out there, we're sitting in the office or at home now. The operators are our voice and ears of the facility, and we really have to engage with them to understand and make sure that they understand what we expect and what we need to make sure that they're working safely and the environments are healthy for them to work. We do have internal aviation where we fly our workers offshore and inshore. We have boats that service and bring supplies in and out. But if somebody gets sick, just like COVID, which we're talking about today, we would go from operating one medevac a month to more than what anybody would expect these days. And we'll go further into that. But you can see the distance that we're dealing with from the heliport to one of these facilities could be up to 100, 120 miles out, which makes a round trip medevac of 240 miles or 4 to 5 hours to get that person back to the hospital. On a daily basis, we're operating about 1,000 people offshore. So you can see the potential that we have and the high risk with more and more people. I think Larry stated it, where we have to make sure that any safeguards we can apply, we do to prevent that infection, whether it's COVID or flu or other respiratory infections offshore, to then further prevent any type of spread. So early on in the pandemic, we wanted to mitigate any of those potential spreads or from getting out there, but we really didn't have the research or the like testing capabilities early on. We did implement all the safeguards that we thought we could, from daily or pre-flight test screening, such as medical screenings and temperature screenings. We know temperature screenings don't catch much unless you get very sick. And then it is the reporting culture that, ask somebody if they have a sinus strip or a headache, they don't know that it could be COVID, so they may deny it just so they can get off to work. So it's been a challenge from the beginning, but we've been able to implement some of these safeguards and increase that reporting culture. A lot of things that we worked on early on was identifying cleaning schedules, disinfection plans post a positive case. One of the biggest safeguards that we wanted to get to was pre-flight testing, but early on, when we had a patient present with potential COVID symptoms, we would have to fly them just like a typical medevac, cardiac, or or any trauma patient to an emergency room to hopefully see that they meet the criteria to test them. Sometimes being up at midnight talking to hospital staff and management to convince the emergency room doctor to write an order to test them. And it wasn't the end there. We still had to wait early on 3, 4, 5, 7 days sometimes for those results. And as y'all probably may have dealt with too, is what do you do with those facilities that the individual came from while you're waiting on those results? So we quarantine them in place, we maintain operations, and we monitor until we get the test result back. That was early on, although it did evolve. It was quite challenging from the beginning. Luckily, since then, we were able to identify the need to make sure that any positive case was caught before they went offshore. So we implemented pre-flight testing. It still wasn't a quick turnaround at that time. It was still two days. So we had to put those individuals in a hotel until we were able to get the results, and we didn't want to mix them with anybody. So we had to manage that with security, make sure we fed them, catered, provide them with, recreational things to do in their rooms so we weren't bored, monitor, mental health, different things like that. So we knew that was a burden on the employee well-being and the organization. So as we found quicker testing strategies or opportunities to get results faster, we jumped on it as soon as we could. So we went from contracting 3 hotels one time down to 1, or 1 night stay at that time, a 12-hour turnaround, which helped. But we were still keeping people in hotels and managing that. And then the FDA authorized the Abbott, or one of the molecular tests, and we took advantage of that. Before it was available to us, it was only available to emergency rooms, and those test kits. If you could easily obtain the test equipment because it's nothing new there. It was just a test kit and the cartridges challenge. And now we're seeing more and more manufacturers developing that too. But we weren't just leaving it up to testing. We made sure. One thing I missed on the previous slide is each of these facilities, we do have offshore medics on each of those. So they're the ones responsible for implementing the offshore response plans. From the beginning, it was, like I said, it was hard to improve the culture of reporting. But whenever somebody did report potential signs or symptoms, we wanted to get them isolated as soon as possible, because what we knew about the virus at the time, the more symptoms you have, the probability of being more contagious, like any other virus. So the quicker we were able to isolate them and contain it, hopefully decrease that spread, because you're in a really close knit environment there. So that's still our goal. We've been able to manage that to the best of our ability. And then as it evolved, we have changed from that 1 night quarantine or testing results to that rapid or 15-minute result. And we've added additional testing, serial testing behind that. So you get the pre-flight test, you get a 3-day retest offshore, and then now you get a 6-day retest offshore. And those serial testing is where we're catching most of our positive cases. So it is working, but we are still getting people to report symptoms early. And that's our goal, to hopefully, minimize spread at a facility if it does get out there. And then to add on the safeguard of vaccines, we talked about the hierarchy of controls, and we stressed that vaccines are our highest engineering standard to prevent it. So we're increasing those vaccine rates by education and trying to explain or get to know some of the vaccine hesitancy issues too. But from an IH perspective, my background actually since high school has been a paramedic, and then I got dragged into the safety and health field after a few semesters of pre-med, and but I enjoy it. I see the proactive and then the reactive, and I think that's helped, especially during this COVID pandemic, to identify my offshore knowledge of operations has allowed me to really understand what they're dealing with out there, what their capabilities are, and what their challenges are. And right now, what we're dealing with are challenges with kind of COVID, I guess, what's the term? I forget, but just tired of dealing with COVID and wear a mask and just the long haul of that. But we're just trying to keep up with it and do the best we can, and just keep reiterating the importance of preventing and mitigating that. But we did
Benjamin, just few minutes left.
Good. I only got two slides.
15 minutes flies. I understand.
So we did get a lot of support from local and industry support representatives, where we were able to get some peer-based reviews and best practices documented and shared with others. And then the last slide here, we talk about IH. Yeah, we talk about IH, we talk about prevention, but when you really get down to the grits of it, what else can you do in an open environment? And ventilation is a high piece for preventing and mitigating infectious disease and other IH-related chemical, fungi hazards. So we put together or reviewed a lot of these articles, did risk assessments at each of these facilities, and learned a lot from it and shared with others. And they were very, very well received. And it's not just a COVID mitigation, it's for all indoor air quality mitigations. But we'll turn it over, and I think that's it.
Okay, thank you very much. It's very interesting because this is something from the industry itself, and it's very interesting to see what's going on there or at the remote location for Chevron. My question, once again, we don't have anything from the audience yet. I promised you I will get back to you with questions later, but my question for you is, so ventilation, your ventilation study, and the measures to kind of prevent the spread of disease using kind of HVAC and other approaches from the industrial ventilation. How would you rank the ventilation among other measures that you applied? Because you said vaccination is our first line of protection. Is ventilation also a big priority from your point of view, or it's just a supplement? How do you feel? Because there are many different opinions. We sometimes the studies on COVID and ventilation are inconclusive in many cases. We really don't know what do we need to do to do more ventilation, or to limit it, not to make it spread around, especially potentially on the like oil platforms or ships. This could be the system where you potentially cannot fully control. But at the same time, of course, if it's respiratory infection, if it's respiratory agent, so of course we always start with engineering control. So what's your feeling? Mm-hmm.
Yeah, no, I appreciate it. That's a fair question, and it's definitely not a higher safeguard than trying to prevent it, or from the hierarchy of controls you want to implement usually a tiered approach, right? You don't want to just think that you eliminated the hazard and not put people in PPE in a potentially hazardous chemical environment. So I do look at it as, I guess, similar to PPE. If you do have that hazard in the environment, what can you do to mitigate it if it does get out there? And ventilation is one of those controls. And like I said, not just for COVID, but also for other infectious disease control and indoor air quality. So I definitely don't want to put it there alone, but it's hard to compare to other higher preventive safeguards that you can, well.
Okay, thank you very much. BJ, we appreciate very much, and we wish you well and wish everything to be okay with your home. We know that you left your home for a few days because of the hurricane, but hopefully, and yeah, maybe our experts about climate could be made responsible for what's going on around us.
Thank you
very
much.
much.
Meet you in person one day. Yeah. Thank you.
So, and really hope to see you also in Tomsk. It's really very nice city. I've been first time 2 years ago there. Okay, thank you. Okay, and so our
Андрей,
next speaker.
одну секунду. Можно я одно слово скажу? Для аудитории здесь, дорогие коллеги.
Dear colleagues, those who are connected remotely, you ask your questions in the chat, but you can come up to the microphone and ask all the questions to the lecturers. Thank you.
Very good, thank you. It's also very good. But generally, the plan was that the questions will be sent to me, and I will kind of pass them to the speakers. Okay, our next speaker, and I'm very proud that we have Dr. Anthony Harris. Dr. Anthony Harris is a medical doctor. He has a brilliant educational background. He has an MBA, he is MPH, and he works for a company named WorkCare. And this company, I had a chance to see the innovation that Mr. Harris promotes and personally participate in their testing and in invention, actually. First time I heard the presentation of Mr. Harris in Colombia, right? How many years ago was it? Like 2 years ago in Colombia. Right. It was very, very interesting, and I'm still impressed. And I am sure that Dr. Harris should go to Tomsk and just to the audience, to medical professionals, paramedics, many people just demonstrate what they do with remote sensor technology for ergonomics assessment. And this is exactly the topic of his talk. It's sensor technology for ergonomics assessment, the role of innovations in remote industrial hygiene. Anthony, I'm listening with great interest. Please, thank you.
Excellent. Thank you, Andre, and thanks to everyone for the opportunity to speak to you today. I know we don't have too much time, so we'll jump right into the presentation. Indeed, all about how we can leverage remote technology, remote sensor technology for mitigating risk for musculoskeletal injuries, ergonomics, right? And what you see before you right now is our ecosystem at WorkCare in regards to how we leverage remotely our expertise in delivering care 24/7 to manage injuries. And indeed, we're doing a lot of work in the oil and gas industry. And we're going to focus in today, like I said, on how we help mitigate risk around musculoskeletal using remote sensor technology. We call it bioergonomics, right? And the reason we call it such is because traditionally ergonomics is measuring the environment to try to understand the impact to the human anatomy, right? And what we're doing is actually measuring the physiology, the human anatomy response to the environment to understand the impact that individuals are having from the work that they're doing. And we all know this is a big problem globally. The number one type of injury we see commonly in the workplace, costing billions of dollars a year in direct costs from a healthcare standpoint, and usually 3 to 10 times more than that when we talk about opportunity costs. So let's jump into it. And this is how we think about our approach to mitigating risk for musculoskeletal injury. We first think differently about it, right? And when we talk about how we leverage our different thoughts around it, it's all about worker health continuum, right? Going from tertiary, secondary, and then primary prevention, and being able to leverage this technology at each level with the hopes that we're doing more primary prevention, right? Preventing injuries from happening in the first place, as we are all steeped in industrial hygiene hierarchy of controls. We obviously want to do what we can to prevent. And we talk about applying this technology to uncover hidden data. And what I mean by hidden data is simply using sensors to help understand that workers are exposed even day one of a job to work that may be risky for them, for a shoulder injury, a back injury, or something similar. And so what we want to do is use this data right away to help mitigate a risk of injury throughout that worker's career, and maybe the first month, the first 2 months of their working in a job place. And just kind of our own makeup, right? I can't tell that the work I'm doing, maybe reaching overhead or pulling pipes and things of that nature, is going to cause me an issue until I have pain. What we can uncover with this technology is that I'm exerting higher levels proportionate to what the baseline of that work should be for a shoulder, and therefore I can understand that individual's risk and help mitigate the risk from intervention standpoint. So let's talk about how we apply this. It doesn't matter if you're talking about one worker or a whole line of workers. We can leverage this technology simultaneously to do remote ergonomic assessment. And we can do this while individuals are doing their normal job. Obviously, this case in the image is a manufacturing setting, but certainly we've done this in oil and gas, we've done this in chemical manufacturing, etc., and it's all done remotely so that you're capturing data that almost is impossible to do when you're talking about working hundreds of miles away from the nearest ergonomist. And we're able to do this no matter the shape or size of the worker. We've fitted NFL players, former NFL players. We fitted petite 5'2" in stature in individuals, and we can capture that data no matter where they're located, right? And it's all connected so that you're drawing insights from the data and leveraging the data to mitigate risk at any location. And so as we talk about what the objective data is and what it looks like, it is exactly as you're seeing on your video screen now, where the worker on the left-hand side here is leveraging the technology underneath their coveralls, again in a manufacturing setting in this case, and we see their muscle activity as they're actually doing their normal job. You're seeing different shades of colors here from blue to yellow to orange to red, and the further the colors shift towards the red, the more exertion that they're enduring to perform their normal job. And so our clinical algorithms that we developed recognizes this data, uses this data in concert to understand, is this individual at increased risk for shoulder injury, a back injury, a knee injury, etc. And we can do this analysis literally from neck all the way down to the knees. And we'll talk more about that. And what we're doing even beyond just the remote sensing is then layering on AI, all right? And that AI skeleton that you're seeing now is capturing motion of the individual, as well as us capturing remotely the muscle activity. And from the concert and conflation of the two, we can draw deeper insights into the risk of workers, no matter where they're located. This technology has been around for some time, right? When I'm talking about the actual sensors that are used to look at the muscle activity, it's called surface electromyography. It's been around since the 70s. We've adapted it in the remote setting so that we can glean insight again without having to send individuals to go capture the data. So imagine workers using this in a suit format, shirt and shorts, and they can don the suit, go do their normal job as we capture the data. At the end of the day, they take the suit off and they're done. And we have a robust set of data around the ergonomic risks for those individuals for their particular jobs. And this data is captured at the same level of intensity that and rigor that we utilize in the clinic itself, and it has been peer reviewed in terms of its efficaciousness. And the whole goal of this is to shift us forward into individualizing ergonomic assessment. Classically, we can only glean, by doing one-offs, individual assessments that we then extrapolate for an entire line of workers. And there's been limitation in terms of the speed to do that and the resources to do that, right? But leveraging this technology, bending the cost curve, we're able to then capture a lot more data and objectify individuals at a price point that doesn't make it prohibitive to individualize our approach like we do in individual medicine. And again, we call it bioergonomics, or capturing, again, physiology of the workers to understand their risk for injury. And we deliver this in a way that allows you, the experts in the field, to capture this data remotely and apply it using simplified risk levels, right? On a scale from 1 to 12, 12 being the maximum risk. And you're able to then stratify that risk across the entire workforce at a location and understand where are your riskiest jobs, where are the hotspots that you need to attack first, and then granulate down that data so you understand, is it shoulder risk, is it back risk that's driving those higher hotspot areas. We have, I won't show you this video in totality here, but I do want to fast forward just to show you a little bit of what the data looks like. And so you can see in this example, we break down each of the job functions into tasks, and we can see the different levels of risk from hand and wrist, back strain, shoulder strain, elbow strain, the levels of risk from different types of injury for each particular task. And again, this granulates down very well to help you mitigate risk, specifically with your ergonomic interventions. And we'll talk about how we apply that, those interventions here shortly. So when we look at then our clinical expertise that we deliver, layered on top of this data, it really is profound what you're able to give to your corresponding health professionals and to intervene, right? Again, classically with tertiary prevention, it's recovery from an injury. Secondary prevention is, hey, I have pain, what do I do about it, right? But now that we have this rich ergonomic data, we can, before pain ever shows up, intervene so that your workforce never experiences any deficits or any drops in productivity from musculoskeletal discomfort, as well as certainly musculoskeletal injury. And so as we zero in on what we can do with recovery and return to work, we can get baselines on workers. And we know that if, God forbid, they are injured, we know where to get them back to in terms of their baseline. If we look at then our secondary prevention, we can now remotely capture data and deliver interventions remotely, leveraging the expertise of athletic trainers, delivered through a remote platform, coaching sessions for the workers, because now we can see where the workers are in their level of risk, let's say for a shoulder injury, and coach them on body mechanics and see that objective improvement of performance and decrease risk, again, leveraging this remote sensing technology. And even something as novel as leveraging exoskeletons for improved ergonomics is objectified now, and we can measure the performance of these remotely as well. Classically, we can only, when applying exoskeletons, survey an individual and say, how does it feel while you're wearing it and while you're not wearing it? Does it feel better, right? Now, we don't need to rely on subjective data only. We can objectively show that their exertion has decreased for a particular area because the exoskeleton is operating efficaciously. And that's what, again, drives safety, drives prevention, and allows us to do more remotely. And then along with that secondary prevention, we can set limits for exertion. Maybe not job rotation, although you can do that. It can be limit on exertion below thresholds that we can now measure that will produce increased risk. And so what do I mean simplistically? Have a worker go perform a job, and you know that at 5 hours of that job, the shoulder risk goes up. So you can have them perform that job for that amount of time, and then rotate them or have them do other activities that then don't contribute to increasing risk for shoulder or be it back or knee injury. Again, objective data setting limits on musculoskeletal risk for injury. And then we're talking again about baselines, right? Getting a baseline on a worker, understanding their risk from day one of the job, and being able to do surveillance on that individual over time so that you're mitigating risk before that individual ever has any symptoms at all in regard to their risk for back injuries or shoulder injuries. Again, all driven by this objective data. And it's as simple as this, right? You have a worker go out, put the suit on, perform their job, and you're capturing that data remotely, and you're able to then, again, leverage this data in the way that we've discussed thus far. And at the end of the day, if you have pre-existing conditions, we can capture that as well. Let's say a pre-existing shoulder injury or shoulder pain, we can then see how the job is uniquely impacting you as a worker and help mitigate that risk because of your pre-existing condition. All things that become now possible with this remote sensing technology. I won't go through these slides in detail here, but know that the aging workforce is something we can now do something about in regards to understanding the level of risk as we get older. We know that the aging workforce has about half the capacity at the age of 65 as we did from a strength standpoint at age 25, right? And so what that means when we're talking about being able to perform a job, if we conceptualize it in this way, ability to perform a job pretty much stays constant from an exertion standpoint, right? But as we age, again, our recovery time lengthens for our muscles to recover, and our strength decreases, right? And so as we age, we need to exert more of our own capacity to achieve that job function, and we can now measure that effect in terms of increased risk for injury with this objective data. Very powerful, very effective in terms of mitigating risk of injury. And then last but not least, it's scalable, right? Because we've been the cost curve and allow you to do really deep ergonomic assessment, you can do a number of things very quickly, starting with first, setting goals for your ergonomic interventions, doing all the training necessary to capture this data remotely for your workforce with online training, and then do things like A/B testing. And that is simply testing an ergonomic solution, one against the other for solving maybe a common problem with a new tool, and seeing which tool is best or which method is best for decreasing the risk for that ergonomic hazard in the workplace. And again, all done remotely so that you're making the best decision before you shell out a bunch of money, capital, for that intervention. And then you can set best practices. Now that you can measure the best way to perform a job most safely from a musculoskeletal injury standpoint, that becomes then your standardized approach to that job and best practices. And then again, as you capture worker baselines, you can move into doing actual surveillance, things that we've only dreamt of doing across an entire workforce because it was cost prohibitive. Now we can do this on a routine basis in the same way we're doing surveillance from a respiratory hazard standpoint or hearing conservation, etc. So with that, I'll stop there. We can get into questions because we are at the 15-minute mark. Thank you very much.
Thank you very much, Anthony. And once again, I so far don't see any questions, and I understood that people are invited to speak at.
There is a question coming. Yes. Andrei? Thank you, Anthony. That's a fantastically interesting presentation. I'm impressed beyond the limit. And the question is, as far as I understand,
your testing is being done for standard industrial operations? Or do you take each and every worker to be tested? So my question is, we cannot change the procedure, operational procedure for the worker. For example, a person has to do this and this job, or this operation at his job. Then what is the way to minimize the risk of injury if you cannot change the way the person is doing his job? Something he has to do.
Absolutely. Thanks for that question. So what we're able to do when the work itself can't be modified, which happens commonly, we're able to leverage new solutions to see how we can decrease exertion. And that's what it's all about, right? There's three tenets of this. There's frequency, we'll start with engagement, how hard the muscles are working. Then we look at the duration. For how long in a period of time is the muscle working that hard? And then frequency, how often is that muscle having to work or fire, right? And so now we can talk about interventions that decrease any one of those three prongs with this objective data. And that in turn decreases the risk for that overexertion injury. That could be something as simple as a new tool for that same job. It could be something as simple as improving the biomechanics of that worker. A good example is back injury risk. Bending forward or lifting. Oftentimes, individuals, when we do this testing, don't fire their glutes, their gluteus muscles. And that is a known risk factor for back injury. And so we can coach them on, hey, you're bending over, you're lifting, you're bending at your knees, but you're not engaging your glutes. And we can actually get them to do so better because we have data showing how the muscles are being overexerted in a biomechanics way. So there's a lot of different solutions that we couldn't apply before because we did not know it was an issue or couldn't see the issues. Now we can.
Okay, great. Thank you very much, Anthony, and I'm very...
Можно еще один вопрос?
Dr. Karpov, are we okay?
Another question, if possible. Another small, quick question.
Знаю, что...
So as far as I understand, first we work on some general recommendations, but then we go to more personal recommendations. Then we can actually measure each and every worker on site. Is that right? This approach from general to more individual?
We start with the macro problems that may exist, and as we solve those, engineer out the hazards perhaps, then we can get to individualized interventions to help prevent injury. Absolutely. And that's the golden chalice, right? The surveillance piece of it that we can do now.
Yeah. I also have a question. We are out of time, but I still probably would like to ask. Dr. Harris, so ergonomics probably is just the first step, right? It's not your full horizon, because you generally can think about measuring more parameters about human body. You can also, using the same information systems, you probably can collect respiratory information like breathing rate, other parameters like that. You can read heart, because all the methodology, as I understand, is derived from the cardiogram, right? From the cardiogram.
Yeah, absolutely. So this endeavor is the beginning of a cadre of sensors that we can leverage remotely to mitigate heat stress injury, to mitigate fatigue even, and we're doing so in concert with the musculoskeletal. Absolutely.
Very good. Thank you very much, Dr. Harris. And okay, our last speaker for, thank you. Our last speaker for today, last but not least, as we say. So it's a person whom I know for many years already. It's Dr. Boris Revich, He is a great scientist, one of the best scientists I know in Russia, and he is a chief researcher and head of the laboratory for predicting the quality of the environment and population health at the Institute of Economic Forecasting at the Russian Academy of Sciences. He's a medical doctor, professor. He is also a Nobel laureate for his work at the climate and public health. He is also an advisor to European Bureau of WHO and UNEP, and we are really very honored and happy to have you, Dr. Revich, and your topic, climate and human health, risk assessment and prevention of disease at the remote location. So thank you very much, and we are listening.
Большое спасибо за приглашение.
Thank you for inviting me to this conference. First of all, thanks Andrei Karchevsky, whom I know for quite a long time, since the time of his previous old job, and I'm always happy to see him in Moscow. And great thanks to the Center for Corporate Medicine that I finally have an opportunity to visit Tomsk. You have been inviting me quite many times, but I never had a chance to. But I'm impressed with your city. It's the second day I'm here, and every day I'm exploring something new. Now I think this is one of the most beautiful and nice cities in the country, and I believe it should be third after Moscow and St. Petersburg. This is incredible. Not because you are, the food is nice here that you give me all the time, but every day, every hour in Tomsk, I find something new in terms of people, architecture, food, and so on. This is an amazing city. I travel a lot around the country, but these feelings cannot be compared with anything. Not too often I feel this about some Russian cities. Some key items before my presentation. Unfortunately, I cannot be at the end of the conference at the closing meeting because I have a meeting with the rector of the medical university. There was a lecture yesterday at the medical university, and the Q&A session was quite nice. But first thing I wanted to say that it was quite right when you opened the conference yesterday. You mentioned the demographic problem in Russia that is experiences toughest time. I was very lucky. I graduated from the first Moscow Medical Institute. The faculty was called the Faculty of Sanitation and Hygiene. Now it has a different name. In Tomsk, you closed this department. It is interesting thing that the head of the Department of Hygiene at Tomsk Medical University moved to Moscow, was the organizer. Then he became the rector of Medical University in Tomsk. Then he moved to Moscow and was the organizer of the Department of Industrial Hygiene in Sechenova University. And my first research work, which was a huge scandal, was devoted to social hygiene assessment of children with donor disease. Then the head of the faculty was the ex-minister of healthcare in the USSR, a person who started his career as a psychiatrist in Kazan. Then he went up the career ladder and reached the Minister of Healthcare as like Mr. Potapov. who was considered to be the best minister of healthcare in the Russian Federation. But my first work was a scandal because the parents of the person with that disease were drinking too much, and the whole study was irrelevant. But this is not the matter of my point I'm trying to make. Then I was studying the environmental epidemiology. And after the Russian Federation was established, I became the member of the International Association on environmental epidemiology and was included into the World Association. At that time, I was the doctor of medical sciences, and as I believed, I did a lot for the Soviet Union, but we still lagged behind the developed international countries. The cooperation with CDC was the project leader of the first project for children. 5 projects, this Harvard School of Health, which is the best school in the world that deals with public health. Yesterday we discussed this with the rector, especially the need to develop the concept of public health in Russia. Because in Russia we put a different emphasis on this concept. How much time is needed for a doctor to see the patient? How many beds do we need in the hospital? This is something different. The public health is something different, not just counting the beds in the hospital. Then I talked about the Russian healthcare during the COVID pandemic. The result was not funding of the healthcare in Russia these days. There is a shortage of qualified staff. The salary of staff leaves much to be desired. Then the reduction of beds in the hospitals. All this resulted in the fact that Russia holds the first place in the world in terms of excessive mortality from COVID. We are the first. This is absolutely true. In August, Rosstat published exact numbers on mortality. Epidemiologists believe that the principle of the excessive death rate is not from COVID, but from all other diseases. There are different reasons for death that should be taken into account. So if you want to go into the details of what is going on with the demographic situation in Russia, please see the report, Population of Russia. This is a regular report of the Center of Demography of the Higher School of Economics. This center is named after an outstanding scientist, Vishnevsky, a doctor, a medic, who invited me as a medical doctor to the Economic Institute. And then academician Shatalin, who was the academic advisor to President Gorbachev. He believed that we cannot develop economy without a social bloc. So the Center of Demography was established at our institute. I was the head of the laboratory, and I'm still am. So we collaborated with the School of Economics, and our institute is still focusing on this topic of study. Right now we are doing some research for the government. We have direct contacts with the government. We are preparing a new demographic report. The difference is that there is a huge economic bloc consulted by your academician Akambekan, our recommendation is to sharply increase the funding of healthcare. But my opinion, this will not be done. But we are researchers. We have to share our opinion. We have to state our position. For this year, the healthcare system would be reduced. This is not a secret. This is published. So next year, the healthcare system will be reduced again next year. Let's see how our country will survive considering the historical crisis and the downshift in the birth rate and the increased number of deaths of the able population. Your center is doing the right thing, dealing with the working people. The person that blessed me in the medical community to be involved into the climate change issues is a person, Nikolai Zmerov, who was the head of the Institute of Medicine of Labor. I think you have his contacts, the contacts with his institute. He was promoting the health of the working population program. This is the main task from the point of view of preserving the health of the working population, which dictate our economy. But he was not successful in all the matters. So Nikolai said, when the European Bureau of the WHO, with which I was collaborating a lot on the ecological problems, they proposed to deal with these issues of the climate change, and the year after, to my absolute disappointment, it was included into the Great Academy. I think this was a mistake. It lost its independence. He said that it is quite interesting, and at the meeting he made a presentation, and we, during the first Russian conference on climate change and health. And then after a few years, in 2010, myself together with my colleague, a wonderful infectionist, an outstanding infectionist, Viktor Maleev, we published the first book, Climate Change and Health of the Population in Russia, which I presented to the CCM. This is the second edition, which was published last year. So this is the first aspect before I...
Я украду 5 минут обеда. Андрей, но не...
But I will steal the 5 minutes of our lunch. Not your lunch, but still I want to do so. Andrei said about the risk assessment, and I fully agree that it is not fully developed in Russia. Andrei knows this well, but we have environmental risk assessment and risk management quite well developed. Unfortunately, my good friend and colleague, Professor Avaliani, died from COVID. He was the one that implemented this methodology. This methodology is published by the Rospotrebnadzor recommendations. He made a good career and joined the Academy of Sciences using his methodology of risk assessment. Unfortunately, it is quite mechanical at the moment. When the ideologist leaves, his work becomes useless. Of course, there are some students or his followers that continue his scientific work. And I believe that the potential you have in your center should give you all the opportunities to cover the wider population, like the Arctic. All shift workers work quite near the villages. Professional risk is a local risk. And Andrei was right when he said about the small groups of people that he studied. With the risk assessment, when we talk about risk assessment applying to Russia, and we discussed this with my colleague Professor Belyanin, 100,000 excessive deaths a year we see in Russia from environmental pollution. And this number was mentioned in the report of the State Council. The report was called Environmental Protection to Protect Future Generations. This is just the name. And as you believe, there are many things to be done in the future. So the third aspect I wanted to mention, this was I will talk about the Arctic. Medical University is quite interested in the Arctic. There are some proposals regarding the improvement of work in the Arctic. Arctic is the priority in our country. And when Vladimir Putin 5 years ago was participating in the conference in Solikhard, it was called Arctic, the Territory for a Dialogue, and I had so the work in the Arctic is quite interesting. So before I begin my presentation, I want to tell you that we've just published another 6th report, APCC. This is intergovernmental, not international, but intergovernmental group on climate change. And I have been the member of this group for 8 years, 2 terms. It received a Nobel Prize in 2007, together with the president of the US group, Albert Gorham. In Glasgow this year, there will be a big conference at the higher level devoted to the climate change. The position of Russia. Russia signed the Paris Treaty. I know a number of international conventions in the field of environment that Russia had signed. I had to work a lot to prepare the Stockholm Convention on stable organic compounds. I have been dealing with this for quite a few years. This is similar to Agent Orange that was used in the United States. When I was in Vietnam at the big conference, I saw this with my eyes. And Russia has a special approach to international treaties. Russia signs them and then whatever it goes. Russia signed the Paris Treaty, and according to the degree of the Russian government, they are developing the National Adaptation Plan. I saw this plan. This is not written properly without full understanding of the essence of the problem. However, the representatives of the Ministry of Health were part of the supervisory board on the first adaptation plan financed by the European Bureau of the World Health Organization. That the WHO organized using the German money. I was the initiator of this plan. It was implemented on the basis of a wonderful Arkhangelsk Medical University. Now it is called Northern Medical University. So for 3 years, this project has been implemented there. We were able to analyze the main idea, and we didn't really knew what Mr. Prokhorov was intended to do. He was not really interested in collaboration, and for many years I had to force them the representatives of different ministries and departments to sit together and discuss the issue, and then we were able to reach a certain result. The students are taught on the issues of climate change, on health change, on health problems, and so on. The Lomonosov Federal University is also there. They also teach the same things, and next year there will be a regular conference on climate change and health, and there will be a different session devoted to health issues. And I hope I will be able to participate. Which is more important, the President of the Russian Federation now has the Mr. Eldergeich. He turned to be a nice and quite adequate person. He understands what is happening, and he tries to do his best as long as his status allows him. Then Ms. Romanovskaya, director of the Institute of Global Change and Ecology, institute named after the academician that did a lot during the Chernobyl accident, and was also one of the leaders of the group of IPCC experts. You see that climate in Russia is growing compared to the rest of the world, and the climate in the Arctic is growing even faster. Climatologists deal a lot, and particularly the Institute of Arctics and Antarctics. I'm quite disappointed with the fact that a wonderful person died, a person of the Arctic health, Mr. Shapovalnikov, and I don't know what is the situation right now there. These are the data of the main geophysical observatory where our climatologists work. Here you see what is happening in Russia, and this is what is happening with the heat waves, which is our main concern as epidemiologists, and their impact on the health. When we published our book on climate change and health, I took it and went to the Ministry of Health in Moscow. I'm not an outsider. I came with my colleagues with whom I studied and or so on. So we gathered a meeting at the higher level, and they thought I am crazy. What are the climate change problems compared to the shortage of beds, medicine, and so on? There were a lot of deaths during that period, and were were no place to bury the people, and there were critical surgical operations, and people were treated in extremely bad conditions. You will have these presentations, I will leave them, and you will have a chance to see them in more details. You see what is happening in our northern and Arctic cities, where there are 4 such cities with which we work, Murmansk, Arkhangelsk, Irkutsk, and Magadan. All the articles I mentioned are published in Russian and English. Right now we're preparing another work for publication. These are the risks to health during the climate warming in the Arctic, and I will report on those risks in the big conference in St. Petersburg. This work was done in Arkhangelsk region and the Komi Republic. We have quite good contacts with Rospotrebnadzor. This year for Canada was extremely bad. You cannot imagine what was happening in Vancouver. 45 degrees. They built some storages with ventilation, with air conditioners. They put the mattresses there, and people were just scrolling there to have some rest from this extreme heat. Siberian wax?
We probably should keep the session, and so we need to finalize. And I even don't know how for us to be able to listen to your full lecture. It would be absolutely great for us to hear it all. But it's just timing for us to conclude. Any chance that you can go to your conclusions now? And then maybe continue during the second part of the lunch.
Хорошо, значит, я вам могу пожелать всего.
Okay, I wish you all the best. I will continue in Russian so that people hear me. But I believe that my comments were quite important for Russian audience.
The session, it was very, very interesting session, and we sure request the full presentation of Dr. Levich recorded, and it would be great for all of us to look at that. But I would like to thank everybody from American team who took part in this session. Thank you very much. Great job, guys. And thank you, Boris, for very, very interesting topic that you discuss today for all of us. I think that the session will be first step for all of us to continue implementing a risk assessment paradigm and concept in different countries. It's not just United States, not just Russia. Yeah, but step by step, I'm sure with such a great group, such a great community of experts, everything possible. I wish you all health and happy autumn, and then I hope we meet next year all together, maybe in Tomsk, Russia. Thank you very much, guys. Thank you.
Андрей, спасибо большое. Я хотел поблагодарить от имени всей.
On behalf of our audience, I would like to thank our nice friend and moderator Andrei for gathering this wonderful and brilliant team of experts highly professional. It was extremely interesting to hear to the reports, even for people who do not have any professional education, experience, and knowledge in this sphere. Andrei, thank you very much. We will be waiting you all in Tomsk at the next conference. Thank you.
Я бы сделал предложение на правах самодератора. Может быть, мы все же пожертвуем еще 10 минутами обеда и дослушаем Бориса Александровича, потому что это крайне важно, крайне интересно и просто я думаю, что все со мной согласятся.
Я прошу извинения, конечно, я как преподаватель укладываюсь лекционно, но вот все-таки не высказать какие-то соображения я не мог. Значит, проблема, забудем слово «вечная мерзлота». Мерзлота не вечная. Ее пучит, прошу извинения за это слово, но это пучение, это уже инженерный термин при деградации многолетней мерзлоты. Вы посмотрите, она сокращается. Проблемы с инженерными коммуникациями.
We still see that there are some problems with engineering communication. What does this mean? This means that this can get into the sewage that are quite old. Everything is published and well known. This is the destruction of the road structure. Such giant companies as Rosneft and other companies, they order specific report from the experts that analyze the climate changes, especially at oil pipelines. For me, as a specialist in medicine, 20 years ago, there was a problem how to assess the health of the population that suffers from oil spills. This is the problem that doesn't exist in any country of the world. When I wrote to my American and Canadian colleagues, they thought I'm crazy because no one would drink water polluted with, contaminated with petroleum products. I brought a group of pediatrists from St. Petersburg because in Moscow they cost much more, they are more expensive. There was a huge oil spill in Usinsky region. Gastroscopy was conducted in children and the situation was quite negative. Unfortunately, I was not able to publish those materials as I wanted them to be published. There will be a session today during this conference, but unfortunately I will not be present there on air aviation. The destruction to different facilities, air facilities and so on. I will show you a few slides later. And this one, for example, talks about the prevention of consequences of low temperatures. There was a wonderful laboratory in Moscow, the laboratory of microproduction, microclimate, which developed these guidelines for low temperatures. I would like to remind you that in the Soviet Union and in Russia, they have a great school of physiologists that dealt with the low temperatures. This was at the Novosibirsk Institute by your academician Kaznachev, whom I personally knew. And respect. This is a new direction which we don't know a lot about. And when I heard for the first time in the APCC, these are fundamental problems. These are psychological problems, consequences of heat. Talking about COVID, do not forget that we are living right now in the post-COVID time, when COVID encephalitis is developing, COVID depressions. These are not international works, but there are a few Russian publications on this topic. Please look at some maps on permafrost. These are weather anomalies in 2016. This one is published in English. I didn't publish it in Russian. On the Arthrax cattle burial grounds. Then this was Siberian Vox epidemic in Yamal. The Rospotrebnadzor system was quite efficient there, and as a result, the monograph of Tatiana Popova was published discussing this situation. This is what is happening with Siberian encephalitis. This is the forecast of incidence of tick-borne encephalitis. Here in Siberia, the situation with ticks is also not so promising. This is our work together with geographers. I work closely with the Geographic Society, with the Faculty of Geography. We are good friends. These are cartographers that have amazing methods, modern methods, concerning the issues, how to provide medical care through transport roads during adverse meteorological conditions. So please look at this paper. It is very interesting. So these are the economic assessments. What will be the cost of road destructions due to the permafrost? This is the WHO project that I mentioned at the beginning. I'm already mentioned intersectoral interaction. There was a lot of money allocated for the laboratory base. This is excessive days rate regarding COVID. I also said a few words about this. These are post-COVID depressions. And that is all I wanted to tell you. I'm ready to answer any questions you might have, but again, we are running out of time, and we want to have lunch, of course.
For the presentation and the rich information that you passed to us. You stated in your presentation that the Russian healthcare will decrease. In which aspect and why? Thank you.
This is a very good question, but the answer is very long. Do you mind that we talk in person, and I will try to explain my position, because this answer is not so fast. We can talk during lunch. More questions? Okay, thank you, Professor Revich. If there are no more questions, then we see you back at 1 p.m. We have 2 sessions in parallel.